I'm here today with Linda Kelly, who's a director of ASET Education, and Jose Molina from Rhythmlink, and Simon Griffin from Lifelines. And there's a collaboration with the four of us to speak and educate patients and families on EEG, neurodiagnostics, the type of products and electrodes we use, and just some information or insight into medical devices. My name is Mary Bettinas. I'm the director for Neurodiagnostics and Epilepsy Services at UCSF Medical Center. And I've been involved in ASET for numerous years, and I am grateful that I can still represent ASET on a national platform and to be here today for Epilepsy Awareness Day. I know we have a different format, and so this will be interesting for us to have interaction since we're not directly one-on-one facing, but we're in a Zoom format. So please, if you have any questions at all, you can put them in the chat section and we can answer those at the end. So who are we? So when we get into who's taking care of your brain, most of you may have had an EEG or have a family member, friends, loved one who's had an EEG. And usually it's performed by an EEG technologist or neurodiagnostic technologist. And we're responsible for actually conducting any neurological procedures or diagnostic procedures, if you will. And there's many different facets of it and type of procedures that we do, which I will get into a little bit as we move through here. So when we look at what type of procedures a technologist can conduct or perform, there's any type of modalities, if you will, or procedures that can assess brain activity, the spinal cord, any of the nervous system. And those type of tests could include long-term monitoring, monitoring in the OR or intraoperative monitoring, assessing brain activity or any of the nervous system, any of your nerves traveling to and from the brain. We call those evoked potentials. And then getting into any other type of procedures that may involve sleep studies, if you will. There's autonomic testing. So you'll hear many different facets, but neurodiagnostic as a whole is more of a global blanket, if you will, for the different type of modalities that a technologist can be able to conduct or perform. When we get into these type of procedures that we do, you think about how this would help support your workup and why you're having an EEG, and then supporting our physicians, our neurologists, our epileptologists, or even our neurosurgeons. And so who are our patients? And that can be anyone from a newborn to someone who's 100 years old. And we're looking at anyone that may have had an unexplained event, who is maybe in the infancy stage of diagnosing for seizures or epilepsy. What type of seizures do they have? Or if someone had, say, an event that affected the brain, being a stroke or a bleed or some type of traumatic brain injury. So there's many different facets, even disease processes that someone may encounter. How does that affect their nervous system, such as multiple sclerosis or MS? And you think about that. And so a technologist really plays a vital role in any of your workup or procedures that you may have done. Our field is very, very unique. I'm one of the many who's been fortunate to be in this field and seen it evolve and grow over time. So I look at this as, when you think about the type of procedures that I had mentioned earlier, there's many different types. And these are some of them, some of the acronyms, if you will, or some of the type of procedures that your physician may request for you, and you may see these. So when you look at an EEG, it can be done as a routine EEG in a doctor's office, or it can be done in a hospital type setting. It can be done in the OR setting, in an ICU type of setting. And that's just basically looking at what is an EEG, right? And then also getting into whether this is done in an outpatient, at home, and then just the different modalities, if you will. And so when you get into what is an EEG, basically we're looking at the electrical activity that is generated by your brain. And we're pretty much comparing one side of the brain to the other, and the waveforms should be symmetrical. And if they're not, why is that? And so this diagnostic tool, if you will, it helps our physicians in diagnosing and ruling in or ruling out any type of abnormalities and what those abnormalities equate to for you. This can also be in EEG when you're looking at it, and a technologist is doing this, and we'll get into some of how the procedure is done. It's very sensitive in looking at measuring the brain activity, because the brain activity is very small. And those electrodes or sensors, if you will, that are placed on your scalp, those are magnified. And then we use computers, if you will, or EEG systems, or any type of other neurological devices, medical devices, to help record that activity. When you think about an EEG, when you think about being in a hospital setting, a lot of this is just helping the diagnostic aspect of diagnosing. It could be, you think about someone, a loved one that may be in an ICU setting. You may see electrodes on their brain, similar to electrodes that are on your chest to pick up your heartbeat, but there's much more, many more sensors or EEG electrodes placed on your scalp to pick up your brain activity, to evaluate the neurological aspects, and to see if there's anything that may help in supporting with a multidisciplinary approach. When you think about someone may have an MRI or a CT scan to look at structures or images of the brain, we also have the EEG to help support in diagnosing. Okay. I thought this slide, just to give a little bit of a representation about EEG and how it's evolved over the years. Dr. Hansberger first was one toying with the idea of what an EEG is, right? And conducted the first EEG on a human. And that human actually turned out to be his son. And with that, looking at publishing these findings way back in, I think it was the 1920s, late 1920s, you can see even in 1958 how it started out, and it was pretty much a very bulky, clunky type of system, and then actually how it's evolved over time into our 21st century. In looking at this being conducted on an adult or even a pediatric population, and the variability of that. But the golden rule, if you will, is really looking at the technologist role in applying these electrodes to your scalp. And marking and measuring your head, which some of you may have already experienced, is a crucial part of a technologist role, because we are comparing one side of the brain to the other, and you want your placement to be symmetrical. And it's a vital role that we instill in all of our neurodiagnostic technologists in teaching and training, because this is sort of the first initiation of looking at your brain activity from an electrical standpoint. And we want to make sure that we have a comparison that is accurate, and it's not due to, if there's an abnormality that's found, an inaccurate placement. And so I highly recommend when you go in for an EEG, making sure that a technologist is marking and measuring your scalp, because it is a vital piece and not to be skipped. Thank you, Linda. As we move forward, just in getting an idea of what the electrode application entails, and a lot of people that have had EEGs probably had some variability, if you will, into the type of electrode application that's been performed. Basically, it's measuring and marking your scalp so we know where to apply the electrodes. And you may have experienced a technologist abrading your skin or rubbing on your scalp gently with a sandy-like solution, just to cleanse off the area of your scalp before applying the electrode or the metal disc or lead, if you will. And there will be several of them that go onto your scalp, probably about 20 to 25, if not more, depending on why you're having the EEG and where you are in your stage of workup. You may have the electrodes applied with a glue-like substance that smells in compressed air. That's actually to help adhere in long-term recordings to make sure that the electrodes stay on, or they may be put on or applied with a paste with a piece of gauze over the top and or tape. And then the length of the recording is really determined on if this is a routine study, the environment that you're in, the reasons why you're having this. It may be on for several days if you're in an epilepsy monitoring unit type situation, or in an outpatient setting where you may be in a ambulatory care facility to have the EEG on for several hours to hopefully capture an event, the reason why you're having the EEG, or it may even be conducted, or you go home with a medical device or being conducted in your home. So there's many different variabilities, but the golden standard of marking and measuring your head and applying the electrodes has pretty much stayed the same. And then the type of a routine EEG, if you will, just to give an example, probably would take about an hour to an hour and a half in an outpatient setting. Your technologist would do an assessment first and talk to you about why you're here, the reasons for it, your type of medications, and then explaining to you what to expect. And then the duration of the recording can run anywhere from 20 to 30 minutes, if not longer, depending on if it's a routine EEG or a sleep-deprived EEG, and then cleaning up and then making sure that all of the proper paperwork and any other type of information that a technologist would need to put into an EEG recording is there before you leave. So just so you understand sort of the facets and the expectations. I wanted to share this slide because I think it's very helpful from a visual standpoint. The shaded electrode placement nomenclature that you see here represents the standard, what we call 10-20 system, and it's a measurement system based on percentages of 10% and 20% to represent areas of the brain in anatomy, from the front of your head, for example, which would be the frontal pole in this, just to give you a little bit of education on this. And that's hence why it says FP1 and odd numbers on the left and even numbers on the right. But with that, we can also, a technologist may be asked to put additional electrodes on. And with that, it's looking at sort of a narrowed in or localizing an area of the brain that we feel that may help us narrow down an area of focus, or an area, for instance, if someone has seizures and we're trying to determine what side of the brain it's coming from. If we can localize and say, oh, it's coming from maybe the left side of the brain, we may look at putting on additional electrodes in one area of that side of the brain or on both to see what side of the brain where the activity starts first or where it's localized. And this can help in guiding from a scalp non-invasive perspective to guide our epileptologists and our neurosurgeons for those that are in a pre-surgical workup of where to apply or to insert electrodes either into the brain or to be on the cortex of the brain for further assessment for seizure resection type of surgeries. And you'll usually see that type of additional, I should say, type of workups in larger organizations or universities that have a collaboration of maybe even a level 3 or level 4 type of epilepsy monitoring unit. Okay. How am I doing on time here? Because I'll quickly, let's see, it's 11:30 because I know we're running behind. So I just want to get into some of the things on what may happen in an EEG and why we are doing these type of activations, if you will. You can have an awake EEG and it'd be completely normal. You can fall asleep, or just in the transition of falling from awake drowsiness to asleep, you can possibly have abnormalities that are elicited. And we want to make sure that we cover all aspects of that. And so your physician may say that they want a sleep-deprived EEG, and that sets us up hopefully for success when you come in for an EEG, that you will be able to fall asleep and will be able to capture or record at least around 10 to 15 minutes of sleep in addition to your normal EEG or routine EEG that you've had done, just to see if there is anything that may be elicited during that time, especially if we already know that one has a seizure or disorder or epilepsy of some sort, to see if their medications are controlling them, or if they may need another type of medication change, or they may need to have, based on the findings of the EEG, maybe requested that we want to have further diagnostic testing, which may lead to an admission into an epilepsy monitoring unit, or based on the findings, a medication change. And there's many other aspects to that as well. From a technologist standpoint, really we try to make the environment as comfortable as possible, a quiet environment. We may turn the lights down, hopefully so that you can fall asleep during your procedure, so we're able to capture this and be successful in what is being asked. There's also other types of activations, and you may have experienced this. There's photic stimulation, where you may see some flashing lights and we have you open and close your eyes. And then hyperventilation, which is a breathing exercise, is another routine activation. And it may provoke certain seizure types. For example, staring spells in adolescence, or you may have heard pettimolar absence seizures. We've been known, or it's been known, that hyperventilation may elicit this type of response that we see on the EEG that may be indicative of this type of seizure disorder. Let's see here. Also in the sleep deprivation as well. So if we can move on in going into after an EEG. So as I mentioned earlier, with a removal of an EEG, a technologist, depending on the type of application that was used, if it was with paste, it should hopefully just come off easily with a warm washcloth. And then, or if it's on with collodion, which is a glue-like substance, a non-acetone remover to break down that glue and then remove from your hair or your scalp, if you will. And this is nothing invasive. So this is strictly just adhering to your scalp. You should not have any side effects from having an EEG done. Just so people are aware, if there's some marks left on your head, it should wash right out. This is not blood, depending on the color of the tool that, or marking pencil that was used. I'll date myself. 35 years ago, we used to use a red China marker, if you will, and it would leave red, sort of a red tinge on a patient's scalp, and patients would think, oh my gosh, I'm bleeding, and really it's not. It's just making sure that a technologist cleans up your scalp really well before you leave. And then based on that, the technologist will have some additional paperwork or some things that they need to enter into the EEG recording itself, and then they will then give that to a neurologist or an epileptologist, who will then interpret the EEG. The role of a technologist is to describe what they see, so that when a physician is reading the EEG, they will have all the information there for them to be able to interpret. And then based on the findings of that EEG, that report will be sent to your requesting physician to help in your diagnosis for that. So when you look at just the scope of practice for a technologist, they're very involved in your care, and probably the front line, if you will, of initiating your care and next steps. Some of these, as I just mentioned a little bit about, once a physician is interpreting this EEG, and depending on the findings, your provider may decide that you may need to go into an epilepsy monitoring unit, because based on the findings, they want to see additional information, or they felt that they didn't capture enough information, not saying that it was incorrect, just that they would like to see more. And so there's different options for that. You could come into a hospital, into an epilepsy monitoring unit, notice that an EMU, if you will, or you can have, you can come into an ambulatory setting and have the EEG placed and go home with a medical device. Usually you may be sent home with a laptop and a video camera, which Simon from Lifelines can actually explain a little bit further. So you can have a recording in a 24, 48-hour home environment, and then that can add additional information as well. So when we get into the ambulatory EEG, there's definitely pros and cons to any type of procedure that you have, but some things to keep in mind. Definitely some of the pros of having an ambulatory EEG, when you think about it, a patient's able to go home with electrodes on their head, they're able to be in their normal environment, and then hopefully in the normal environment, we are able to capture in this time frame, whether it's 24, 48, or 72 hours, some of the events that have been of concern. Some of the challenges that may come up with doing an ambulatory EEG is that some of the electrodes may come off. They may not be securely, or they may become compromised, or something may happen during that time frame, and then the EEG becomes uninterpretable at that point. And then also to just the comfort of patients being able to navigate through to make sure that it's recording, that the video is set up. But we've come a long way with a lot of this. And so there's definitely, there's advantages and disadvantages to everything, but we try to make this as comfortable as possible for patients, and then providing an alternative to a hospital admission. Okay, if you are going to have a long-term monitoring or long-term EEG, continuous EEG, as we stated, it could be considered in an ambulatory setting, but if you're in a hospital setting, the reasons why we're looking at some of this type of stuff is it can be performed in an intensive care unit where someone may be unresponsive or comatose, and we want to see what's going on with brain activity during that time. Definitely to help if someone is in a coma or medically induced coma, the type of medication that's being used will have an effect on the brain waves or electrical activity, and we want to be able to monitor that. Also in epilepsy monitoring units, when we look at these, we're trying to evaluate the events that a patient's having. Is it coming from the brain or not? And if it is, what area of the brain? You're in a controlled environment. You have a multidisciplinary approach, and you have continuous EEG and video that is being constantly monitored in majority of organizational settings and reviewed by physicians on a day-to-day basis. So we look at how a technologist plays a huge role in this, especially in when you're in a hospital setting, right? A technologist has a lot to do with especially maintaining the technical integrity of your recording, making sure that it is a safe environment for you, especially if you're having your medication reduced and you're going to have an event or a seizure. We want to make sure that you have the support from physicians, nursing, and our technologists. Some of the things, though, when we look at from this multifaceted approach, is that you are in a hospital setting, and there might be some just you look at a curtailed type of environment where you can't do some of your normal day-to-day stuff, but we try to make sure that it's as pleasant as possible for you when you're in there. And you'll get to know your technologists, your teams, your physicians very well, because you'll have that interaction with them. And depending on if you're in the EMU or in a non-EMU setting for long-term monitoring, you may actually just be in your room in a hospital setting and saying that they just want to get an assessment or just have a procedure done to help in a workup, such as an evoked potential for for MS, as I had stated earlier, or just a quick EEG to evaluate to make sure that everything is going well. So here's just some examples of what goes on in the life of an EEG or neurodiagnostic technologist. There may be some reading of the EEG and monitoring. When you look at just the several monitors that we have that look at video and EEG simultaneously. And really the golden standard is looking at EEG and looking at the waveforms, and a trained technologist will be able to decipher if it's normal or if something's changing. And having the video actually is very supportive in giving us clinically what is going on with this person at this time, and can we correlate the physical or clinical events that are occurring with EEG at that point in time, which definitely helps us in trying to diagnose or localize an area of the brain of seizure onset. And then I thought it would be great to have just a visual of when we are in the OR, a technologist is in helping assist the epileptologist and the neurosurgeon from a recording aspect. You get a visualization of what actually the cortex looks like, your brain looks like when the skull's removed, and then the type of electrodes that are placed directly on the brain. And then also too, looking at the neurosurgeon may mark certain areas of the brain where there's eloquent cortex, such as speech, memory, motor function. And we want to make sure that we do not remove any part that it would cause a deficit for a patient. A technologist, it's multifaceted. There's a lot that they do. And so I wanted to make sure that everyone was aware of just how their key roles that they play, especially in an epilepsy monitoring unit, but just neurodiagnostic as a whole, because there are so many things that they can be doing from observing patients and monitoring the patients 24/7. Some larger institutions have 24/7 support with a technologist or several technologists on site, recording patients and ensuring patient safety. And then being very supportive during their length of stay in the hospital and part of their surgical intervention and outcomes. If we want to go just to the next slide, great. And I'm realizing in time frame here, the role of the technologist you may see us just as I stated earlier, in an outpatient setting, but also in the emergency room. There may be a situation where someone comes in and before they're admitted, or we might need an EEG to determine if they should be admitted or not. So you may see us there as well. Getting into some of the tools and equipment, I know Jose Molina from Rhythmlink will talk a little bit more about this, but there's different types of electrodes that we use in PACE and glue-like substances. They all play a part, right, in helping us be successful in recording in any type of diagnostic procedures that we do. And I'll let Jose get into that a little bit more. And sometimes, depending on the type of procedures, we may use needle electrodes, but that might be more for an OR type of situation as opposed to an EEG situation. And just to give you just an idea of the EEG itself, and many different channels of recording that we may see as it scrolls by. And this is the EEG recording device or system that is utilized. And it's definitely come a long way in the 35 years in my experience, from a analog type system to a digital platform to a hybrid platform, where now it's a digital type of recordings, if you will, and it involves many aspects of where it can be networked. All of this type of information can be streamed so our physicians can remote in and look. So accessibility has definitely gotten to a point of real time and sort of mitigating having to have a physical presence if a physician, you need someone to look at something immediately. Also too, this can sort of be compact, where you have sort of your strobe light already here tied into the system. So if this is a portable system going directly to a patient room, we're able to take everything with us. So as we go through some of the next features here of what it is and qualifications, I'm going to turn it over to Linda, and she can speak a little bit about the qualifications of a technologist, credentialing, licensings, etc.
Thank you, Mary. I'm very excited to be here today. And Mary has been at the Epilepsy Awareness Day the last couple of years, so she's probably a familiar face to some of you. And on behalf of ASET, we thank her for representing us so very well. And she's been involved with ASET for years, like she said, so it's our pleasure to continue working with her. And as Mary went over a little bit about what the Neurodiagnostic Tech does, and also sort of what it would look like from the routine EEG to the ambulatory to an inpatient stay in an epilepsy monitoring unit. I'm going to talk a little bit more about the technologists and the qualifications. So you may or may not know this, but currently no licensure or regulation is required to practice neurodiagnostics in any state. Employers may have various requirements for hire, such as formal training, years of experience, or credentials. Credentials are very important because it's a nationally recognized exam that basically tells people that you are qualified, that you are proficient and competent. And that's so important in the role of the neurodiagnostic technologist. Training experience is very important. Also important to be a neurodiagnostic tech is if you are caring and compassionate, because you're going to work in healthcare. You're going to see sick patients every day, and you need to be able to treat every patient as if they were your most beloved family member, because you want to make sure they're receiving the highest level of care. So a commitment to compassion and care for your patients. You have to be able to interact. You need strong communication skills so that you can interact with patients and their caregivers and other members of the healthcare team. You're going to talk to nurses and physicians and everybody else across the board in the hospital or healthcare setting. You want to make sure that you're comfortable communicating with other people. It's also helpful to be committed to lifelong learning. As you can imagine, with the brain, there are constantly new developments being discovered from research and technology. As they advance, so does our knowledge about the brain. So it's very important to want to be a lifelong learner. And I think most people are, so they get that. And it really makes our job that much more interesting. It's never stagnant, which is important. So recently the ASET board came out with a definition of qualified. What does it mean to be qualified? Because you want to make sure a qualified person is taking care of your brain. And some of the bullet points here are credentials. So we're going to talk about them a little bit more in depth, but like I said, it's a nationally recognized exam for different modalities that a tech can take and pass, and they have some of the alphabet soup initials after their name that Mary showed earlier. There's a different exam for each of the different modalities, and techs who take and pass that exam demonstrate competence, and that's really important. If they have a set level of education. ASET believes strongly in education. I'm going to talk about some of the neurodiagnostic training programs in a minute. And the other thing is continuing education. That's really important. It is a requirement if you're a credentialed technologist, but it speaks to your commitment to, again, lifelong learning. As new developments arise, it's important to stay abreast of whatever's coming out, whatever's coming down the pipe, whether it's research or technology. And that helps you to be a better, well-rounded technologist who can provide the highest level of care for your patient. So it's very important to seek out qualified technologists. Beyond those three requirements, neurodiagnostic technologists have a set scope of practice. They work under the direction of clinical leadership or a physician. As Mary mentioned, the tech runs the recording, might write a description, but it takes a physician to generate the final report and treat the patient, to sort of direct the patient's care. And the EEG is a piece of the puzzle in that. They use the EEG with the MRI, with your history, your symptoms, other tests you've had done, and they put all that together to come up with a treatment plan. And ASET is the National Professional Society for Neurodiagnostic Technologists. This statement, along with the scope of practice and other documents, are available on our website. What is the background and training? So most of the schools offer either an associate's degree or a certificate program. There are currently 2 accredited bachelor's degree programs with at least 2 more in the works. Many of the associate degree programs have, I'm drawing a blank on the word, I'm so sorry, articulation agreements with 4-year colleges. So once you're done your 2-year degree, you get out, you get a job, you can go back to school. I personally did that, and I'm proud to say I don't have any student loans, which is really great news for anybody out there. My employer was happy to pay for me to go back to school. So that was really a great benefit. And they offer a variety of degrees. There are currently 29 accredited programs. They have both online and seated programs. So I'm going to show you a map of where the programs are spread out across the country. If there's not one in your neck of the woods, the online programs are designed to support that. They really came about because there aren't that many schools. If you think about going to school for a business degree or psychology degree, there's probably 1,000 colleges and universities across the country that offer that for you. This is a much smaller profession, but really so rewarding that I think, you know, any of us here today can kind of speak to that as well. Once you graduate a 2-year program, you are eligible to sit for your credentialing exam. And most hospitals require some level of education or a registry to be hired, or a registry within a certain amount of time. So it might become a condition of employment. So it's really important to invest in your education because many of the schools are partnered with colleges, community colleges. They are affordable, or they at least offer scholarships or financial aid to make, you know, if you decided you wanted to be a neurodiagnostic tech, that can be a real reality. This is a map of the schools across the country. Your goal should be to go to a CAHEP accredited program. CAHEP accreditation really speaks to the quality of the program. It's been vetted by an organization, CAHEP, that also looks over other healthcare professions. So X-ray, respiratory therapy, nursing, they accredit healthcare programs. And CAHEP accreditation is a rigorous process. I'm a former CAHEP accredited program director, so I know the rigors of it. And basically it requires submission of a self-study, you undergo a site visit, and you also have to submit an annual report with certain metrics that show, you know, are your students graduating? Are they getting jobs? Are they passing their boards? Really important information to show that you're providing a quality education. So a CAHEP accredited program really demonstrates quality on an annual basis. So you would want to look for a CAHEP accredited program. If you visit the ASET website under the education tab, there's a listing of all the CAHEP accredited programs. You can click on them and find out, you know, go directly to the school's webpage. You can find out contact information. You can find out tuition information. So there's a wealth of resources available on the ASET webpage if you were interested in pursuing a career in neurodiagnostics. Places of employment for neurodiagnostic technologists. Where do we work? Anywhere there are patients. So hospitals have neurodiagnostic labs, sometimes in the hospital. Mary mentioned, you know, we might be in the operating room, in the ICU, in the epilepsy monitoring unit. You might see us there, helping to provide your care on a daily basis. Techs are employed in research and biofeedback labs, outpatient clinics, private doctors' offices, equipment vendors. There's also techs employed in education. So I'm a former tech that went on to teach. So, you know, that's another avenue. And now even more than ever, techs are employed from companies that do outside monitoring. So you might be at home reviewing records, or you might go into somebody's home and set up an EEG. Simon's going to talk about that a little bit more as a possibility, but there's no lack of employment for neurodiagnostic techs. And it's really great because it's like snowflakes. No 2 EEGs are exactly the same. No 2 patients are exactly the same. So it's really an exciting profession that allows you, you know, you never see day in and day out. It's not sort of the same thing every day. You never get bored, which is really nice. And you have all these options. You know, if you decided, I don't want to work in a hospital anymore, I want to go work someplace else, you have options. It's a growth-oriented field that really kind of gets people excited. You'll find that neurodiagnostic technologists are very passionate about their profession. I love this slide Mary put together here, and it just kind of depicts all the different places that a neurodiagnostic technologist might work, whether it's research, a patient room in a hospital, the EMU, with the neonatal population or pediatric population, and even the extremely sick patients in an ICU setting. So we do see sick patients. Not everybody comes in off the street, kind of walking, talking, and happy to be there. Like Mary said, our patients run the gamut. So they can be, newborn babies all the way up to the elderly. They can be really healthy and they just have had some questionable events. They want to try and sort out where it's coming from, to somebody who's in an ICU setting, possibly comatose, and trying to figure out why aren't they waking up. So we do see a variety of patients in a variety of settings. So some of the pros of becoming a neurodiagnostic tech, excuse me, there's a somewhat flexible work schedule. So some hospitals have 24/7 coverage. So you can work during the day, you can work at night. You might be on call for an emergency situation, or you might provide weekend coverage. And this actually, the flexibility really works out great, depending on your family life and what other schedule you have going on. So that's really worked out well for me. And I'm sorry, I have to cough again. Excuse me, I'm so sorry about that. Most programs are only 2 years, but there's a ton of employment opportunities as there is a nationwide shortage of neurodiagnostic techs. There's not enough graduates to fill the roles. So if you're willing to relocate, you can pretty much get a job almost anywhere and be board eligible as soon as you graduate in 2 years. And you make a decent salary, even just coming out of school. I'm really surprised even recently. My students from a couple of years ago that graduated and got jobs, when they told me their starting salary, it's a lot better than it was when I started. So it's nice to see that it's kept pace with the times. But it's also unique and rewarding. So when you talk to healthcare professionals, a lot of people don't know that this is even a career path they can choose. So it's really unique and people enjoy it. Like I said, the neurodiagnostic professionals are very passionate about their jobs. Thank God for mute. I don't have to hack in your ear too much longer. Earning potential, this is what people want to know about a lot. If I go to school for 2 years, I invest in my education, what am I going to make when I come out of school? So as you can see here, the salaries vary depending on your role and where you live. But like with most other professions, the more education you have, the more experience you have, the higher salary you'll command. And the one thing I can say that's unique to us is that because of all the different modalities in neurodiagnostics and the potential to get credentialed in each of those, generally the more credentials you have, the higher salary you command. So it's about lifelong learning and really investing in yourself. And it is an in-demand career because graduation rates with 29 schools, there's not enough graduates to fill the open positions. Neurodiagnostic credentials, you keep hearing me mention this. There are several national organizations that administer these exams. Again, a little bit more alphabet soup, but you can take credentialing exams for EEGs, for both potentials, LTM, IONM, NCS, EMG, and sleep studies. So all the different procedures that fall under the neurodiagnostics umbrella, you can take an exam, pass an exam, and get initials or credentials after your name. Credentials are very valuable. I'm going to stress it a little bit more when we talk about licensure. And again, here's kind of the laundry list of the different credentials. ABRET is kind of our main partner society. In fact, when ABRET first started, they were part of ASET, and then they went separate probably about 20 years ago. And these are all the different exams you can take. The EEG And CLTM would probably be the most common ones you would encounter in an EEG lab or an epilepsy monitoring unit. But since Mary showed you that awesome picture of the electrodes on the scalp from the neurosurgical perspective, the CINM or the intraoperative monitoring credential, you would run into that as well. ABRAT also offers lab accreditation, and this is a lot like HEP accreditation for your school. The ABRAT lab accreditation process speaks to your policies, procedures, your commitment to quality, and basically, kind of vets your lab. And you can be an EEG lab, LTM, or NIOM program. Coming down the home stretch. So ASET supports licensure. So you heard me mention a couple minutes ago that there is no requirement for licensure. However, ASET supports licensure because we know how important your brain is. We know how important it is to have somebody qualified taking care of your brain. And as a patient, as a consumer of healthcare, you should know that. Many people walk into a hospital and assume that whoever's taking care of them is properly credentialed, has gone to school, and that's not necessarily the case. So ASET has taken a position where they support licensure, especially licensure that involves credentials. Because again, credentialing is a nationally recognized exam that speaks to competence. And that's really important. ASET has a multitude of resources, again, on their website for licensure and advocacy. We have several committees that's all they do is work on supporting licensure, different advocacy avenues to try and get the credential and licensure, underway and recognized, whether it be from legislature, insurance, risk management, human resources, different points of interest that we think might recognize the value of credentialed technologists. The benefits of licensure. So a licensed technologist would have to prove competence. And that's really important because the technologist is oftentimes, they're running an EEG and they can recognize if something critical is happening and alert the appropriate physician to respond. And sometimes delays in care can have very negative consequences. So it's really important to have a qualified tech that recognizes that. Also, the techs are aware of different interference or artifacts, as we call them, that can look like EEG, and they can troubleshoot real time to make sure you're getting a really high quality recording, and that your physician can use that recording at the end of the day to help in your diagnosis and treatment plan. So it's really important to kind of stress credentials and licensure. There are some people that say, well, I don't want licensure because I'm not registered. And, really the sign of the times is that we need to be able to prove that we are competent. And the best way to do that is through credentialing and licensure. What's new with licensure? So since this event is usually hosted at Disneyland, we thought it would be nice to mention that the California chapter of ASET has been granted a licensure grant. They have a model bill that they're going to introduce in early 2021 to the California legislature. And, it is a rigorous process. It's not sort of a guaranteed success story. There's a lot of work that goes on behind the scenes by the California chapter and ASET licensure committees to sort of support them. But we were pleased to be able to give them a financial grant to help, employ a lobbyist and make connections in the California state legislature. How can you help? So if you're sitting here today wondering, well, I didn't know that techs didn't have to be credentialed. I didn't know techs didn't have to be licensed. What can I do? You might just think, I'm just one patient, I can't have an impact, but that's simply not true. If you know somebody, maybe you know a neighbor, a relative, a friend of a friend who's involved in politics, reach out to them and tell them you support this bill because you value your brain, you value credentials and licensure, you recognize the importance of qualified technologists performing your studies. And if not, you can, even if you don't know anybody, everybody's local or state legislature has email addresses now, they have websites available, they have their office phone numbers available. there's a big election coming up, so people are around right now. They want to hear from their constituents. They want to hear from you. They want to hear that it's important that you want to make sure that whoever's taking care of your brain in the field of neurodiagnostics is credentialed and licensed and qualified. Because, you know, subpar care is a real concern, and it should be. And we really at ASET, we don't support that. We want to make sure our professionals and our patients are really getting the best level of care. So as I mentioned, ASET supports our patients, they support our profession. We really have made a commitment to patient care. It's part of our mission and our vision, so I don't want to lose sight of that. And of course, if you have any questions, we'll be on while Jose sets up his presentation. I think he's next, but you can also visit our website. We have a YouTube channel. We have a lot of resources if you were interested in a career in neurodiagnostics, or if you just want more information about licensure, we have that as well. And I apologize for the cough. And I'm going to stop share so Jose can start his. And I'm also going to check the chat. I don't see any new questions in there, but if you want to unmute yourself and ask any questions of Mary or myself, we'll be around while Jose sets up.
I am ready as soon as I can get control. I have a host disabled participant screen sharing.
All right, it wasn't me, but apparently I am you did make me a co-host. So I think I might need to, Jenny might have to make you a co-host because I don't see that as an option for me to do.
Got it. Great presentation. I really enjoyed it.
Thank you. Thanks to Mary.
Yeah, you guys did a great job.
I just sent her a private chat to ask her to give you screen sharing capabilities.
Awesome. Thank you.
Linda, this is Simon. You could tell her to do the same for me because we're going to have the same problem and it's mine.
You got it.
Thank you very much.
I just clicked a couple things. See if that works. And she says you guys are all set.
Yeah, it looks like it's getting ready to work.
I see your presentation looks good.
Do you guys hear me? You guys hear me okay?
Yes.
Perfect. All right, so I only have my laptop and I only have my presentation up, so I apologize ahead of time because I don't really see the controls or anything else. I will be toggling through. With that said, thank you so much. That was a great presentation, Mary and Linda. That was awesome. And I'm going to talk to you a little bit about electrodes. My name is Jose Molina. I'm the West Coast Territory Manager for Rhythmlink. And I've got 15 years of neuro experience. Started out as a biomed, repairing EEG, EMG, long-term monitoring equipment, and then moved into a sales role. And in one way or another, I've been in the neurodiagnostic field for the past 15 years. So a little bit of experience. And what I learned in that time was being able to go to all these different labs, and listening to Mary and Linda and also Simon talk about it, people that do those jobs are so incredibly passionate about what they do. And when I got into electrodes, I didn't realize how intimate of a product that was for everyone. So really excited to be able to speak to it, because I had a crash course in electrodes and what it meant to people when I joined Rhythmlink. Let's see if it'll let me go to my next slide. Okay. So real quick overview, what we're going to talk about. Please keep in mind that this is intended to be a basic overview for patients, so they can have a little bit of a background when they go into their studies and know what to expect, and also sometimes to know there's other options in some of the things that they're being exposed to, right? So we'll talk a little bit about who Rhythmlink is, what we do, electrodes, their pros and cons, touch on skin health, and then maybe take some questions at the end if anybody has some. So what do we do at Rhythmlink? Well, we connect patients to clinical systems. Rhythmlink looks at the process of connecting and disconnecting and is always looking for ways to improve the patient experience, and at the same time, deliver that data to the clinicians in a way that's most useful for them. So again, talking about electrodes, you start realizing there's some innovation and some room for growth there. Some quick stats, right? 65 million people around the world have epilepsy. And you can read through this slide, but the one that really sticks out to me is the last one, where 6 out of 10 people with epilepsy, we don't necessarily know where the cause is. And to me, that's a very impactful number. And if we can connect these patients and get these clinicians good data, we can only improve the chances for a positive outcome for these patients. And as you start looking at the process and with electrodes, you start realizing, there is some areas for improvement, and we'll go over some of the innovations that have come through in the past few years. So here you see Doc Brown. I don't know if very many people who haven't seen Back to the Future, but this is always such a clever video, clever scene for me, right? He's trying to read Marty's thoughts, but that you can't read their thoughts, but you can see the electrical activity on a micro level, right? And that's a homemade electrodes, which I always thought were very clever. So this is nothing new for most of you. Having a good understanding what the clinicians are looking for is that microvolt level and where that activity is occurring, whether it be the frontal, temporal, left, or right in the brain. How do clinicians get that information to their sophisticated computers or EEG, intraoperative monitoring systems, nerve conduction systems? No, through the medium of electrodes. Just like there's a variety of tools available for us all to do different jobs, there's a huge number of electrodes, and the right ones for the right job are important. So here you'll see electrodes come in several different configurations, and depending on the patient's needs, the clinician will pick the best way to connect that patient to their system, be it a sleep study, a routine 30, 40-minute EEG, an ambulatory or an in-home EEG, long-term monitoring for when they're in a hospital for a few days, or functional brain mapping, where they're actually preparing for surgery and looking for certain areas in the brain where they may be more impactful when they resect or take a piece of that tissue away than others, usually for tumors. Needle EEGs that can be used in the emergency department or in the ICU when patients enter an altered state of consciousness. But you can also see here, there's a variety of different types of electrodes that people use. And This would be a new image for a lot of you that have had EEGs. Just really quick, once they've got the patients connected, they're able to start collecting good data for those clinicians, allowing them to move forward with the planned course of treatment. And here's a nice EEG. Most people, when they see this, what they're looking for is clean signal and symmetry. And Mary talked about that earlier. But this would be a typical EEG. I'm sure most of you already seen this. So now we're kind of at the meat of this talk: electrodes, and a lot more electrodes. I always knew electrodes were part of these exams, but didn't know how impactful they were to the users and the patients. Some of the electrodes that are used are disposable, some of them are reusable, some go in the skin, some go on the skin, some can stay on during an MRI or a CT, and some of them need to be removed. Each of these have their place in epilepsy, right? But they also have their pros and cons. So looking at the traditional reusable electrodes, this is what most people had as the gold standard when they first started doing EEG several years ago, right? So the pros to these were they worked reliably for decades. They were reusable, so they didn't have a whole lot of waste. Most clinicians have used in the past and have a high level of comfort and trust in reusable electrodes. Some of the cons. Traditional reusable electrodes can't go into the MRI, and that created a whole list of other challenges that kind of were accepted in the industry at the time, but through improvements through technology, we've been able to kind of counter that. There was a need to disinfect these electrodes every patient use. Of course, there was a potential for cross-contamination, especially with COVID today. That's a really hot topic. Just a quick factoid: American Journal of Infection Control, December 2018, showed that 25% of the cleaned reusable electrodes still had bacteria present. 8 of these bacteria species identified, 7 were potential risk for causing human infection, right? Second con is cleaning protocols are not necessarily standardized in every hospital. Researchers collected swab samples at a number of hospitals across the United States over a 10-week period. 31 of the 124 electrodes that they tested positive for bacteria. So there is some room for standardization, but again, we really want to pay a little bit closer attention to that disinfectant when we are using those reusable electrodes. And another con is they're kind of expensive to replace. So single patient or disposable electrodes, right? Pros. You don't need to disinfect them when they're a one use and go ahead and discard. Very minimal, if any, opportunity for cross-contamination, especially with COVID today. Some of these designs were innovated and actually can go into the MRI today. Cost justification for hospitals, where they at one time thought it was a really high cost potential, started really looking at the financials and the cleaning man hours that these technologists are spending. It doesn't make a whole lot of sense nowadays, knowing that these technologists are paid a certain rate, to have them cleaning out this, electrodes when they can do more studies instead of spending that time cleaning electrodes. And also reduction in infection, which causes a whole other list of issues for the hospital. And another type of electrode are these single-use MRI and conditional electrodes. So here you can see it was designed in a way that allows you to disconnect the machine from the electrodes in a quick way. And those electrodes are MRI and CT safe, these particular ones that you see here. So talking a little bit more about the MRI and CT electrodes. What's on the need for these conditional MRI electrodes? No need to hook up and rehook up patients, at least not in the traditional form. I didn't know this when I first started working with electrodes and EEGs, but the process of getting MRIs was a pain point that many clinicians just accepted as the norm. And let me give you an example of that. So patient would come in for a long-term study and end up in the ICU. They get traditional reusable electrodes applied. A day later, a neurologist finds that they need an MRI. Makes a call to the EEG lab manager and say something like, John Doe in the ICU needs to get an MRI, please send them down to imaging. The manager would then send up a tech to take off these electrodes, which could take up to an hour and a half, depending if they use collodion, and get that patient unhooked, and then hopefully get them into their slot for the MRI. I didn't know this, but a lot of these MRIs are booked 24 hours in these hospitals, so they could be brought in at really odd hours, which causes a logistical nightmare for people that are having to coordinate with secondary labs to bring in technologists or call them in from home, or any of these other timing issues that get presented during these clinical or these ICU settings. So what does that mean for the patient? Well, they get their skin abraded one more time, which offers another opportunity for infection, where they could just have them connected one time and reduce that secondary opportunity for infection. And then as we look at some of the labels on those products, we want to make sure that it was clear for the end users and the patients to see. The term that you see here is going to be the one that's most applicable for us, would be the MR conditional, which means there's no known or specified MRI hazards for the MRI environments. And of course, MR unsafe, you know that it's not safe to be in the MR. Secondary types of electrodes that are used, I'll touch on these ones briefly, are the stickies. Good for one-time use. Patient's skin needs to be cleaned. Sometimes patients who use excessive lotions causes some challenges in keeping these electrodes on the skin. I've seen it where people clean the skin with alcohol and then, maybe a little bit too quickly apply these electrodes, and it takes away the sticky characteristic of the electrode. So you got to have a little bit of experience using these sticky electrodes, but overall, they're pretty reliable. Can be used for recording and in some cases stimulating nerves. Needle electrodes. We can see these being used in the emergency department for stat EEGs or in the ICU, also for OR cases for recording nerves during stim and brain surgery or spine surgeries. Just like the recording area on the disc electrodes, these pick up signals through the actual needle, and the needle itself is a recording surface. And back to surface electrodes. Shape matters. As you can see here, there's a couple different designs that were created recently, and we've had positive results on these in a couple different areas. So as you look at these different shapes, you can see that flat or that grid shape, the slim cup, and the deep cup. The slim cup, you can see there towards the bottom, right here, has a broader rim, which allows there to be the pressure dissipated over a larger area, compared to maybe one of these deep cups that has that thinner rim, which concentrates that pressure on the skin. And of course, the flat one has the largest surface area, which would dissipate it evenly over the whole body of the electrode. And what does that mean for the patient? So as you look here, there's a couple of studies that we did internally, and looking from left to right, we're talking about the cup design. So I just spoke to you about the deep cup that has that thinner lip that goes around, which concentrates a little bit of that pressure against the skin. And then the slim cup, which is a little bit more, improves the dissipation a little bit more over the skin. And of course, the web, which has the best. Now, over time, you can still see at the very bottom, there's some redness left over from the deep cup. And then the extreme example on that web is there's nothing on that skin that shows that electrode was ever present, right? So depending on the shape of electrodes, it can affect the skin health. These were on for about 72 hours of continued use. And the key takeaway here is how the electrodes leave the skin over time. Why? There's concentrated pressure on the lip of the rim and the electrode compared to the web electrodes where the pressure is evenly distributed over the electrode. There's absolutely an obvious improvement there. So that said, now that we've educated you briefly on being connected to EEG systems, let me introduce Simon, and he can speak to you about technology that's come a long way and how you're no longer limited to EEGs in the hospital or the clinic setting. Thank you.
Thank you, Jose. First of all, can anyone hear me? Let's verify that. And
Yes.
Yes.
great, excellent. And Jose, if you could unshare your screen, then I can go ahead and share and get going here. All
Stop
righty.
sharing.
Yep, I should be
you
able
go.
to share now and share it now. And there we go. So hopefully you can all see my screen. I believe you can, at least it appears to be on my screen. So, well, good afternoon, everyone. I'm sitting here in central Illinois, and I think God was trying to remind me I was supposed to be in sunny Southern California because it was 26 degrees when I woke up this morning with a feel-like temperature of 21. So yeah, so I'm wearing my purple, and I wish I was with you. And as you can see from my background, I'm in the plains of Illinois right now. So I'm going to talk to you about in-home alternatives to hospital testing, when it's appropriate, when it's inappropriate, but really just to give you a brief overview of what's actually available today, because things have really changed over the last few years. And I think it's great to help people know that they can get EEGs done in different environments. So who is Lifelines? What are we about? Well, our mantra really is that we create technologies to allow for neurodiagnostics to take place without boundaries, meaning absolutely anywhere. And it really is the case. So for example, I actually just received a note today from a physician from UCLA who's been working in northern Nigeria on a study for patients with nodding syndrome, which is a type of epileptiform activity. And he's in rural communities in northern Nigeria. And he was able to take ruggedized ambulatory video EEG equipment manufactured by us into that environment, record studies in that environment, and transmit them back to the United States for analysis and review. And that's the kind of thinking that Lifelines supplies. We want to try and create the ability to record EEGs absolutely anywhere in the best possible environment. So Lifelines is part of a wider organization. We're part of CIDIS, and CIDIS is a life sciences company with operations in Colorado, Kentucky, Dublin, Ireland, London, and Cambridge in the UK. And we're involved in all sorts of things, not just neurodiagnostics. We're doing some incredibly innovative things in disposable endoscopes, for example, for infection control during endoscopy. And we're involved in other high-tech clinical and medical applications and research applications as well. What I really want to talk about today is the fact that Lifelines has a nationwide client base of companies and customers who provide in-home EEG services. And in fact, over half the in-home studies performed in the United States are actually performed using our equipment. And there's good old Brad and his colleagues at EEG Anywhere. Brad, of course, is the one who's organized this whole event, along with his wife and many other volunteers. And Brad's one of our many clients who goes into patients' homes, sets up equipment, and actually records video and EEG in the patient home environment. Things have changed dramatically over the years. In the last 25 years, we've gone from large, bulky pen and ink type devices, and now a device like the one in the left image here, that's an old grass EEG machine. Actually, it's well older than 25 years. But that device, the capabilities of that device are now replicated in much, much smaller patient-worn devices. So the young man on the right, playing video games with his sister, he's wearing an EEG system that has more channels. He can record, there are signals being recorded for more areas of his scalp than the big bulky instrument of the past. And he's wearing it, and he can wear that for days on end. And it's just a complete change in technology over the last many years. But it's not just the amplifiers, it's not just the EEG systems. The cloud has really made a difference. The internet has made a huge difference. So it's now entirely feasible, and it happens every day, for recordings to be performed in a patient's home, with the data being live streamed up onto the cloud and then remotely accessed and reviewed in real time while the study's performing. And there's some significant advantages to be able to perform studies in this way. First of all, it means that the physicians have got almost immediate access to events that take place. So if if the child that you're the caregiver for, or if you are in fact the patient, have an event, have something occur while you're being recorded in the home setting, the physicians can be alerted to that and go in and view that data whilst the recording continues and see what happens. So it can quickly improve our ability to respond. Furthermore, it also means that people can be looking at the data during the recording to see how well the recording's going. Have electrodes fallen off? In fact, Mary alluded to that in her presentation, that can be one of the problems with in-home studies, is that you can lose electrodes that can then make an uninterpretable study. Well, if the study's being monitored, then it's actually possible to go and take care of that problem. And that's in fact what most of our customers do. They will dispatch technologists back to the home to go in and repair things and fix things, so that you end up with a high quality study for the duration of the recording. So this is just a quick snapshot of our product line. We've been doing this for 20 years now. In fact, the little device, the Truckit Mark 1, released in 2000, just celebrated its 20th anniversary. And I was absolutely stunned when we announced that on Facebook. We had like a little birthday celebration for the original Tracker. I was actually stunned when a tech in Georgia sent me a picture of the system they're still using. So 20-year-old ambulatory EEG products are still in use and still working just fine. And it's quite remarkable, the longevity and reliability of these rugged, bulletproof devices. So these devices have evolved over time, and we now have a brand new device that we launched last year, and it's much smaller, it's lighter, it's much more comfortable for the patient to wear. It can record for longer, it uses rechargeable batteries, so it's better for the environment. So things have really enhanced and improved. I'm just going to quickly touch on some of the things that Mary and Linda spoke about in their presentations. And that, what exactly is an EEG? Well, we know most of you have had one, or you've observed one being performed, and it's the electrical activity of the brain being recorded in the form of to a lay person, what looks like squiggly lines on a piece of paper, except it isn't a piece of paper anymore. It's the screen of your smartphone, or it's a tablet PC, or it's a screen of a computer. And that can be absolutely anywhere, because that data can be transmitted to anyone, anywhere in the world who has the appropriate credentials to look at it. And that's really what it's about. And the photograph on the right there of our physician, who now just has taken a quick coffee break on the golf course. He's no longer actually in the hospital. He can be out and about working, doing whatever he chooses to do, and can quickly access the EEG data very quickly, just by being sent an alert, perhaps by an email, to tell them, go look at this, and then they can jump in and take a view and see what's going on. So there's a trusty EEG machine, just to go in a quick summary, 260 pounds down to well under £1. It's quite remarkable. And from a from a capabilities perspective, that 1990s era digital system, that's one of the early digital EEG systems, has fewer channels than the little £0.5 device that we have today. It's got onboard storage. The technology has been condensed completely down into these tiny wearable devices. So routine EEG, I want to talk briefly about the types of EEGs just to re-summarize. So this is in modern speak in the United States, a routine clinical EEG would be anything under 2 hours in duration. That's actually quite important. And I do want to stress that, because the way in which these studies are reimbursed, they're clearly differentiated now between routine studies, which are below 2 hours in duration, and long-term studies, which are anything longer than 2 hours in duration. And these routine studies typically include hyperventilation stimulation and photic stimulation, different kinds of activations to try and elicit a response during the recording. Oftentimes the patient's awake, drowsy, and asleep. Ideally, we get all three states during that short duration study. And they generally are the first step towards diagnosis of some sort. This is usually your first EEG. And they're typically performed in an outpatient setting, such as a hospital, EEG lab, or a physician's office, but not all of them are performed in those settings. It's now not unusual for your first routine EEG to be actually performed in a home by a technologist who comes to the home with the equipment and performs that study in the home setting. Long-term monitoring or long-term recording or long-term continuous recording is anything now longer than 2 hours. And the typical recording is a day or longer. It's usually in increments of 24 hours. But from the definition of the AMA, the American Medical Association's definition now of a long-term study is anything longer than 2 hours in duration. Now, these are usually now monitored in some way, either continuously, where eyeballs are on that EEG the entire time, or intermittently, where someone will log in periodically and take a look at the EEG, make sure the quality's good, see if anything's happened, if there's any problems with electrodes, if you, the patient, are still in view of the camera, things of that nature. And these frequently include newer technologies where artificial intelligence applications and algorithms can be used to automatically identify spike and seizure activity. So we've now got artificial intelligence tools that will help us, help our clinicians, help our physicians, help our technologists to identify abnormalities and therefore respond much more quickly to the patient's needs. Now, these types of long-term studies, your physician will typically want to look at them every day and report on them every day. Now, in a hospital setting, that's easy. You know, they are there, they're looking at the data in an LTM type lab, and that would be the type of picture you see on the right there, where the image shows, you know, lots of screens, many patients being monitored at the same time. Typically used for localizing and classifying seizure types and so on and so forth. I'm not going to dwell on this too much because some of it's been covered. And I think what's really important is in today's world, the location that these studies is now completely agnostic. And the reason why I raised that point is in the old days, it wasn't. In the old days, these long-term studies exclusively took place in the hospital setting. And now they can take place in many settings. And the way in which it's decided where they should take place really depends on the reason for the study. So for example, if this is a long-term EEG study where the physicians decided they want to remove your medications and see what happens and then help titrate and identify the best level of medication for you, we don't want to do that in an environment that's unsafe. We want you to be in a hospital type setting where people are there, nursing staff are there, people are there ready to respond if in fact you have an emergency type situation. But if this is the first long-term study being done, just simply to try and figure out what's going on, what's triggering, what's causing the episodes that you're having, well, why not perform that in the home setting, a place where it's more likely to take place because of the environmental triggers, and there is no inherent safety risk associated with it. So the location is going to depend on the risk more than anything else. But the point being that you can now have these procedures performed absolutely anywhere. Now, there's something we call ambulatory EEG, and ambulatory EEGs are very often completely unmonitored. These are where you just simply wear a device and you go about your day. You can go anywhere, get in the car, go out to the park. Well, you could if it wasn't COVID, but you know what I'm saying. You can go absolutely anywhere. These are patient-worn devices. These are not dissimilar to what's used in the home with video, but typically straight ambulatory studies are not done with video anymore. A long-term monitoring in the home setting would typically use video. And so we do tend to differentiate now between a straight ambulatory study where it's just, you just wear something and you go about your business and it's unmonitored, and you just come back 2 or 3 days later with a recording, and then that recording is reviewed at the end of that 2 to 3 day period. And it's reimbursed differently. The performance of these ambulatory studies is different, and it's quite different to a continuously monitored study that would take place in the home, the hospital, or any other setting. Again, spike and seizure detection may be performed. So these types of ambulatory studies are typically set up in a physician's office or a hospital, and then the patient's sent home and comes back several days later with the resultant data. So why even do an in-home study? What's the purpose? Why have we spent so much time as a company developing the technologies to do it? Why does it matter? Well, we didn't know it when we designed all these things, but here we are today in a pandemic scenario, a global pandemic happening all over the world. And all over the world, patients are preferring to have diagnostic procedures done in the safest place for them. And in many cases, that might be in the home setting. So particularly if you're immune compromised in some way, and we know many patients, particularly those with genetic epilepsies, can often be very susceptible to other illnesses. So they need to be kept in a very safe environment. So being able to have these studies performed in a home setting can create a much safer environment just for exposure to other things. If for example, the child having the study performed is a special needs child in some way, perhaps they get very anxious going into a hospital type setting. These types of studies done in the home can just simply be more pleasant for them, far less anxiety, and much easier for them to be able to be cooperative during the procedure. So I think that's a very important point, and one of the principal reasons why, for example, Brad and his team really specialize in children with autism, for example. That's one of their specialties, is performing these studies for kids who would struggle to go sometimes into a clinical type setting. Of course, when you're in home, you're now replicating the typical activities that you would do. And as we all know, kids today spend all their time playing board games and not playing video games. And that's why I've put the image up on the screen there. But the point being is that if you are triggered in some way by your environment, then why not do the testing in that environment? So what does the future herald? Well, frankly, the systems are just going to keep getting smaller. Some of you may have seen, for example, the announcements coming out of Elon Musk's company, where they're talking about, devices directly embedded in the skull with electrodes all over the scalp, which become permanently embedded in the subject. I'm not so sure that that's something we're all going to want to do over time. Maybe we will. Maybe in time that's the reality. But I think for most of us, much smaller, easier to wear medical devices are the future. We certainly see artificial intelligence becoming more and more and more utilized. Especially when we do these really long recordings, that's a lot of EEG data to be analyzed and viewed and reviewed. And there's actually, there is definitely a lot of information in the EEG that we currently don't really extract. So at the moment, we're used to looking at, for example, a seizure activity or other abnormalities in the EEG taking place, and they're clearly different to the everyday resting state EEG, and we can instantly see, oh yes, there's something going on there. But there's lots of other information contained within the EEG. So for example, there are artificial intelligence algorithms being utilized today or being developed today to look at resting state EEG in an aging population that can more quickly and easily see the very earliest onsets of dementia long before there are clinical symptoms. So artificial intelligence analysis of EEG is something that's coming. It's very close, and there's going to be some significant enhancements in that over the coming years. I do think we're going to see change in time in how we apply electrodes. That really hasn't been done effectively yet. On the right-hand side there, you can see, for example, a disposable EEG array of electrodes that we developed in our Irish office, and that was used specifically to allow a nurse in a neonatal ICU to quickly apply a set of electrodes to bridge the gap to when a proper technologist, a registered tech, can come in and actually fully apply a set of electrodes. And you'll see, I think, some innovations in electrode design and capability. And Jose, of course, has referred to and shown us some of those enhancements are already improving, because, you know, we want to improve the wearability of these devices, the ease of application of these devices, and also, very importantly, the way in which these devices care for the patient's skin. We want to ensure the integrity of the patient's skin over the duration of a very long-term recording. I actually think one of the biggest changes we're going to see is a significant improvement in the training and education of EEG technologists globally. So in the United States and Western Europe and a lot of the more medically advanced nations, EEG technologists are there, perhaps not in the numbers that we need. But when you get into more emerging markets and more third world type environments, you find that there isn't anyone trained to do perform these studies, and the incidence of epilepsy in emerging markets such as India, for example, or some of the African countries that I referred to with the researchers from UCLA earlier on in my talk, there's just nobody there to do the studies, but the patients are there, and these patients are not just experiencing epilepsy. In many cases, they're experiencing social isolation as a result of their condition. And so, for example, I have a very good client of ours who does charitable EEG recordings in Haiti. They go to Haiti on annual missions to record studies there. And if you're a Haitian with epilepsy, in all likelihood, you've been completely ostracized from your family and community because you're deemed to be possessed. And so to be able to train people internationally to go and perform these kinds of studies, help these patients get the treatment, it's not then just treating their symptoms and condition, it's actually allowing them to become re-engaged with their families and their society. So it's very significant. And so I see significant advances in global training of EEG technologists, elevating the standards of credentialing and so on a global basis. So just final point, I just want to point out that these in-home EEG studies are absolutely available nationwide. We have clients all over the country performing these studies. There's very few states, if any, that are not currently served. And so if you have a need or an interest in having an in-home study, by all means reach out to us. I'll be happy to put you in touch with people who can perform these studies. Here's the Lifelines customer charter. It just tells you who we are, what we try to do, how we try to support our customers, what we truly value and what's important to us. And this is a commitment we make to all our clients, which in turn is the commitment to the patients for whom our clients serve. So I think that's important, and it's a very important part of the company that I founded, and here we are 20 years on still doing. I just quickly want to switch hats here because I'm actually on the board of directors of the ASET Foundation. And the ASET Foundation is the charitable wing of ASET, and this is where we raise money to provide sponsorships, scholarships, grants to people who wish to improve their education in neurodiagnostics. And this is really important. I just want to direct you to this because if you're considering a career in neurodiagnostics and you could use some scholarship money or grant money, go to the ASET Foundation. We're constantly raising funds to provide scholarships and grants. And to date, we've raised in excess, it's actually bigger than that now, we've raised in excess of $250,000. And all of that money goes towards continuing education. So if you are someone who's interested in going into the field of neurodiagnostics, you found the perfect school that you want to go to, here's an opportunity to apply for scholarships to help you in your quest. And in fact, right now, this month is Epilepsy Awareness Month. That's why we're holding this event right now. And ASET Foundation, if you go to GoFundMe and look us up, we have just launched a new fundraising. We're looking to raise $5,000 during this month. And about an hour ago, we'd already raised $760, and this is only day two of it. And I just encourage you to go there, share this campaign, donate if you feel so inclined. Any dollar that you donate will go towards continuing education for EEG technologists. So I just want to make sure everyone's aware of the fact that the ASET Foundation is there, and it's there to elevate the standard of EEG technology in the United States. That's everything that I had to say. And so questions for me or anyone else in the group. And I think the best way to do that is if you want to unmute yourself and ask, go ahead, or alternatively, go ahead and type them in. I don't know if Mary and yeah, Linda's here, I see, and Mary's still here. I'm just for the heck of it, I am going to turn off my background because I'm going to make them jealous because they can see what I've got in my museum here, which I keep in my office. Look what I've got in the back corner of my office there.
I love it.
There's an old Grass Model 8 from God knows when. It still works, and in fact, laying on it is one of my old ambulatory EEG systems, one of the original Trackit ones. But what's so cool, I've got everything. I've got the little pen for pushing the buttons, and I've got the old marker for measuring everything. So I've got the whole kit. So
it's wonderful.
I keep that to remind me as to where we've come from. So, well, thank you, everyone. Any questions? I'll be happy to take them.
I did monitor the chat. There weren't too many questions. We'll give people a minute just to unmute themselves if they have any questions. In the meantime, on behalf of myself and Mary and ASET and Jose and Rhythmlink and Simon and Lifelines, we'd like to thank Brad and Jenny, the Epilepsy Awareness Day organizers, for taking this event virtually. We know it's different, but we also know it's important this year of all years. And it gives us the ability to hopefully reach more people than normal because anybody anywhere can can log in and view these presentations as opposed to just those on site in Disneyland. Although next year we'd much rather be in Disneyland. All right, I don't see any questions coming in, so I guess I'll turn it back over to Jenny.
All right, thank you all. It was a
Great.
pleasure.
Thanks, everyone.
Thank you.
Bye.